So thank you for that warm welcome. Everyone can hear me just fine. It is so lovely to be here, and it's so lovely to have my entire amazing team here as well. So if you have any questions about what I'm about to say, all of these people probably know more about it than I do. Just kidding, but they are absolutely wonderful. Okay, so we are all strongly affiliated with the Stanford Asylum Center for Biodesign, which some of you may have heard of, which has many core principles, but really the mission is to advance health outcomes and equity through innovation, education, translation, and policy. And that's a big mouthful, but I'll break down what we actually do. So most of the time when you start to think, especially in academia, and you talk about tech transfer, you're talking about a technology, and then you find the need for it. And I know you guys don't all do that here, which I'm very, very, very glad that you don't. But oftentimes, technology, then you find the need. But we actually flip that completely on its head and say, if you really understand this need, then you can find the technology. That's probably actually the easy part in all of this. So the way that we do that is through a biodesign process. And some of you, I'm sure, are familiar with this, and others, this is the first time you're seeing this. But there are 3 different phases. Both identify, invent, and implement. So with identify, you're finding a clinical need, and invent, you're developing a disruptive technology, and implementation, you're finding a viable business. So not just philanthropic support, but actually a viable, sustainable business. And this looks all circular and linear, and it's just fine. But as we all know, if you're an innovator, it goes back and forth many different times, and it's much more messy than this clean picture looks. So this is Biodesign's famous slide, and I love this slide because it means that over the last 20 years, the technologies that have been developed straight out of the Biodesign Fellowship or grad class have helped over 13 million patients. Okay, it's a big deal. But then I ask the question, how many of those are pediatric patients? You want to guess? We'll do some audience interactivity. Okay, shout out a number. What did you say? 500,000. Okay, we have an optimist. Anybody else? Anybody else? 10%. 10%. Okay, still kind of an optimist there. But I love that you're an optimist. Anybody else? 1%. 1%. You're making me do math here and calculate. So it's actually only 14,000 before we came along. So 14,000 out of 13 million, essentially we weren't innovating at all for pediatric patients, and we got completely left behind. And as a neonatologist and a pediatrician, this is a real problem. And I hope I never have to show this slide again, but I keep having to show this slide because it is still a very real reality. Industry spends more money to develop health technologies that address the last month of life than on technologies that can transform a lifetime. And this is a problem. And this needs to change. And let's just put it to a graph if you don't believe me that that statement wasn't enough. So you see the little blue bars down there? You see how flat they are? Guess which one's the pediatric approvals? The little blue bars. The others are the adult approvals. Those are PMAs or HDs if you're more familiar with the language of the US FDA. So it's flat and it really isn't growing. Now this is only data through, you'll notice, through 2016. And that was not the most recent FDA report, which we'll go into. I also wanted to talk a little bit, so there's a regulatory problem. We're not approving technologies, we're not inventing technologies. And then there's this whole problem around reimbursement. And I want to spend a little bit of time here because it's very different in the US. I understand you have reimbursement challenges too, but we have some very convoluted ones. So how does your company get paid? You ask anybody how your company gets paid, and every single person in the US will tell you, well, you just look up the Medicare codes. Anybody know what age serves Medicare? Sorry? The aging population. So anybody over 65? How many of my patients are over 65? None of my maternal patients, none of my neonatal patients, nobody's over 65. So I can't use Medicare to do anything, and it's a federal program, so there's only one entity, okay? So what do we have to do? We have to go to Medicaid. Medicaid serves is the public insurance for a poorer population. And about 50% of children are on state-based Medicaids. That means that there's 50 different Medicaids. So every time you have to figure out how you get paid, you have to go to 50 different Medicaids. Number one. Then there's a whole host of other private insurances that are linked to parents' employment. And they're very covert about all this. There's no codes associated. There's no way to get new codes. It's very, very challenging because people just didn't think about kids when they were developing the system. They thought about the people who vote. And I wish that was funny, but it really is. They think about the people who vote, not the people who are going to be our future. So with private insurance, it's linked to your parents' employment. And guess what? People change jobs frequently, and they change insurances frequently, usually on an 18-month cycle. And that means that no private insurance company that actually really runs this market cares about long-term outcomes because it's some other insurance companies, they're paying for some other insurance company's benefit. This is also really wrong, right? This is crazy. It's crazy that we have a system like this, but we do. And so I'm going to tell you all the other things that are wrong and how hard it is to do pediatrics, and then I promise this will not be a downer talk. So people talk about the small market size. We don't talk about small market size. It's a smaller market size. There are few institutional investors. I already told you about reimbursement. It's actually hard to engineer things for little people who might be 500 grams and then grow up to 70 kilo adults. It is hard to deal with ethics, potential to harm them. People don't ever want to have anything public that they ever hurt a child. Get that? Nobody wants to hurt a child. And those children can't advocate for themselves. And then there's this theoretical burden of evidence around regulatory, and I'm actually pretty positive about regulatory, not just because they give us a really big grant that we dole out to all of you, but I actually am pretty positive about them. And so FDA approval, it's there. You have to do it. But you can do it. So let's go back to the problem. Anyone who actually lives in the world of pediatrics knows that this is the world that we encounter every day. And you might be asking yourself, what is this? So on the left, we have adult central line management. A company develops this. There's a quality control system. They, make sure that it's sterile, that things are appropriately placed, right? That's probably a good way to handle a central line. You know what my patients get? That's an umbilical cord. It goes straight into your abdominal aorta as well as your IVC. So you're going into the central vessels of a baby. And right next to it is the diaper. So you might wonder why those have the highest rates of infection. We don't seem to have a problem with this. This is an arts and crafts project that the nurses do at the bedside. And that's how we secure our lines. It's crazy, okay? But nobody ever thought all the things that you do for adults, you can't just slap that on a desiccating and umbilical cord. You have to figure out something that is specific for neonates. But nobody ever picked up that problem until they did. And so, there we go. So there was a company called Novonate that both James Wall, who I know some of you met before, a pediatric surgeon at Stanford, and I were involved with, that later sold to Labry, but we developed this, and it is an umbilical catheter securement device. It's silicone, it is sterilely packaged, you can secure both lines, and it protects you from the diaper. Super simple and easy, right? It's not complicated, but you had to have in mind that you were going to design something specifically for neonates. So we said, okay, we did it once, let's see if we can do it multiple times. And the reason that we wanted to do this was because we knew that the way to actually get devices to patients was to do it ourselves. And so we raised very modest amounts of money, and we're able to have all these companies acquired. So the first one was the umbilical catheter securement company. The second one was mine, which was it's called Emmy, a way to help people manage birth control pills to prevent unplanned pregnancies. And then the last one was a pediatric cardiologist named Bronwyn Harris, who started a company called Tuio that eventually sold to Apple. But all of these only raised $1 to $3 million before they were acquired. And so it was smart innovation that allowed us to do that. And then we said, well, now that we figured out how to do it, we need to share this with everyone because of all the problems I just told you about that drive us all mad. So the FDA also realized that this was a problem. And so they ended up creating, because of that graph I showed you before, they ended up creating 5 different pediatric device consortia, which they give usually around $7 to $7.5 million US dollars every 5 years to, and they then give most of that away. So if you have a US entity, you're allowed to apply to any of these consortia, whether they have pitch competitions and other things, to actually get grants that are usually range between $25,000 and we have one that goes up to $100,000. So keep that in the back of your mind. So these are really starter grants. They don't get you all the way there, but the FDA is trying because they wanted to fix that too. The other thing that people forget about in pediatrics is there's no regulatory filing fees for any pediatric indication in the US FDA. There are incredible orphan drug benefits, so we don't have to talk through those. Some of those are going away, but they're still, they fixed it in the drug market in the sense that they really incentivize companies to develop rare and orphan drugs. And then PCI meetings are something that we can actually do as part of the UCSF Stanford Pediatric Device Consortium, where we can get you a meeting with the FDA if we believe in your technology and want to stand it up, and you're part of our portfolio companies, and we can get you in front of the leadership of the FDA to have an off-the-record meeting before you've ever had a pre-sub. So they don't do that for anybody else. They do that for pediatric companies. And then the FDA is also trying to do a bunch of different things, creating this thing called ShipMD, and then there's this other acronym that's very long. I think there's 5 Ps and an MD, if I'm correct, and that's started by the Foundation for the National Institutes of Health. It's trying to create public-private partnerships. Now this is hard, and this is the US government, and things run slowly there. So, as they do in most governments, we won't talk about our current political situation though, so. Yeah, I know. This is what's happened since then. So this was the report that they put out in 2021, okay? So you can see data all the way up to 2021, and it looks pretty good. I mean, on the y-axis are years, and on the x-axis is number of approved devices. So before I showed you it was maybe 1 or 2 a year, and now it looks like it's more, right? I want you to ignore the green bar, okay? And just look at the pink, purple, and blue bars. It's still better, and I'm proud that it's better. The reason I want you to ignore the green bar is because it gets hyperinflated. So those are adolescents. It's the youngest population that anything would apply to. And really, when they say adolescents, they mean 18 to 21-year-olds. Those aren't really adolescents. Those are big people. Those, big children. And their physiology is not that different. So you're not really designing things for them. They're just saying, hey, we included a couple 18-year-olds in our trial, and so we were able to get this indication. I'm still proud of that, but I also don't want you to think this data gets skewed by it, because sometimes the numbers get a little bit off. So make sure you remember that. It's still, there's sometimes it says 10, and sometimes it says 15. 2020 was a really good year, at least for something, right? And then you're probably going to want to know, what's Impact 1? Well, Impact 1 is probably what my co-director, Kuncheth, and I are most proud of in our entire career, our amazing team that we have. But it didn't start easy, so it started with a UCSF Stanford Pediatric Device Consortium grant back in 2018. We both joined at that time, and then we were able to create Impact 1 about 2 years ago because we realized that we didn't want to just be located in the US with medical devices, because that's what we were limited to, pediatric medical devices. We wanted to make sure that we expanded to maternal devices, fetal devices. That's another political story that we can talk about some other day, why fetal doesn't have a place in the world in the US, and also wanted to expand internationally. So that's when we actually started to further develop our relationship with i4Kids, which I will let other people tell you about today. And what does Impact 1 stand for? So it really is all about advancing pediatric and maternal health technology to impact lives from day one. And this is our leadership team. So you'll see a lot of them here. We have Kunj is here with us, Juliana's here, Elizabeth, Marta, and Elizabeth and Marta are both from Barcelona, and Antje and Anu are here as well. So if you have questions, please just come and grab them. We realized today that we left all the boys at home, so sorry for that. But they're amazing fellows that are working in all different areas, some all over the world. And they actually are all entrepreneurs, and they all start their own projects, which then spin out into companies. So they know what they're doing, and they actually do it. But what do we do? So we accelerate, innovate, and legislate. So what does that actually mean? So accelerate, we take in different projects, no cost to anyone. This is just what we do, and help support them. So they present at our innovators forums. We've had over 150 companies do that from around the world. You can see where we're at. We're on, I love to say that Elizabeth helped us get on every continent except for Antarctica, so I'm still waiting for that one. But a lot of these tend to be really early stage companies, and they're all over the map. So a really good representation from pediatric companies, neonatal companies as well. And what doesn't usually happen in medtech, that a lot of these are female founders, and a lot of these are underrepresented in medicine as well. But what I'm probably most proud of is that all of these companies tend to be really, really young, and yet, remember how many patients Biodesign did in 25 years? 14,000? In just 4 years, all the companies and teams that we've supported, which we'll take credit for too, but it's really all of their work, have treated over 78,000 patients. And this isn't even including this year. We didn't even do our numbers for this year yet. So we're really proud of that. They're able to raise real money and from institutional investors, create real jobs, and we're able to be part of their journey. And we have lots of generous support, but can always use more to continue moving forward. So we do base a little bit of our global reach on the Biodesign extension programs. So we are able to connect with them and promote pediatric device innovation within all these locations as well. And of course, but then we realized there's no place for pediatric CEOs to hang out and to learn from each other, and we keep reinventing the wheel. So we started a Pediatric CEO Summit, and we got to have our second one just last week in New York City, which was sponsored by Deerfield and Kobe Cure. And so we were really thrilled to be a part of this amazing agenda, have a wonderful time, but actually just stop reinventing the wheel as individuals and start putting together our collective energy. And then there's all the work that our amazing team does. So this is Dr. Kunch's project. We said that fetal had no place to go. Well, she is definitely changing that conversation. So there is a condition called LUDO, lower urinary tract obstruction, where you actually have to have shunts placed while you're still in, while your mother is still pregnant. So you actually have to go through into the amniotic fluid, into the baby to put in a shunt. And usually you have to do this 6 to 7 times because they fall out or they get kinked. Well, she has developed one that doesn't, and they're in animal models right now. So has really found a real model for a very small population with a very big impact and been able to really make it happen. All of these are not actually spun out as companies. We incubate them for quite a long time in-house. And then if you want to know about necrotizing enterocolitis and how much I hate it, you can ask me or you can ask Juliana Pearl, and she'll tell you. So the problem with necrotizing enterocolitis is a condition that neonates get, and mostly premature neonates. They get it, and the issue is that we can't detect it, but they can die very, very quickly from it or have lifelong implications. And so we can't tell the difference between their belly being bigger or them actually having a life-threatening disease. So we decided that we were going to find a way to diagnose it. Never thought we'd be in diagnostics, but that was where the need was. And so then we developed technology around that to diagnose it at least a day or two earlier, which is really meaningful. Then as Elizabeth has her own project, which is preventing oral mucositis in children undergoing chemotherapy. It works for adults too, but I like to say it works for kids the best because they certainly have the biggest issue with oral mucositis, which is horrible mouth sores so that you can't swallow or you can't talk, you can't eat. And she has a way to help prevent that with cryotherapy. And then Marta, who's here as well, she's finding a pharmacologic solution because, of course, she's a pharmacist. And by the way, all these people have PhDs, MDs. They're incredibly accomplished before they even come to us. So we can't even take credit for all of their hard work. And to prevent perineal trauma during vaginal deliveries. So you kind of see the breadth of things. We're doing fetal, pediatric, as well as maternal. And the issue really is that we want to make sure that we're always actually entrepreneurs and still in the field actually doing this, because that allows us to have the best conversations and the best connections and be able to truly help people. So then I kind of alluded to our political system a little bit, but there's a lot of things we need to do in terms of advocacy and legislation. We've done some research, and this is from Juliana Pearl, but she found that there was so little pediatric investment. We already knew that, but we decided to put numbers to it, and it's small. We also try to engage in public-private partnerships and participate in public comments. I don't know if you have that same ability, but when the FDA puts out things, you can actually comment on them and say what you think. And it's a really important way to be able to do that. So we use Impact One as the vehicle to be able to do that as well. And we're just starting with that. Okay, so I told you it wasn't going to be all sad, right? And that this is horrible. I'm glad you're taking pictures of this one. So this is a new one. We prove to you you can do it. We keep doing it over and over again, and we believe in it, and we know that there's an incredible mission. But there's also really good benefits to pediatrics that nobody talks about. So we're going to talk about them right now. There is decreased competition. Do you want to have 1% of a market, or do you want to have 80% of a small market? So you can compete against all those other large cardiac companies and get just a sliver, or you can dominate. I prefer domination, so there we go. And then you can obtain a large portion of a smaller market. There are more institutional investors out there. They're still hard to find, and I know that you have some here as well, so that's great to see, but we need more investment. And we need people who are about our mission and are able to turn up the impact dial and turn slightly down the ROI dial, but not all the way down. Still has to be a sustainable business. Hospitals are amazing. There's a really small number of children's hospitals. You don't have to conquer every hospital. Just go after the children's hospitals. They're a captive audience when they're in NICU and in the ICUs, and NICUs are a huge profit source. So I'm really big on neonatal innovation, obviously. And yeah, I said all the negative things about advocacy, but parents are amazing. What would you not do for your child? They're incredible advocates, and you can have a lifelong impact. And regulatory, I told you all about no filing fees and PCI meetings and orphan drug benefits, but that brings real money into companies and gives definitely an incentive. Okay, so it's not perfect, but we're still working on making that better, but we do need to highlight all the reasons why we should be innovating in pediatrics too, beyond the mission. So then this is a totally shameless plug for my team, but we launched a podcast, so tune in because your very own Sophia is going to be on it next week. So you'll want to hear that one. You can connect with us on LinkedIn and see what we're doing, and then we have a newsletter too that we'd love to highlight any of our companies that are in our portfolio and all the work that you're doing as well. And certainly this will be in there next month. Okay.
Yeah, perfect. Brilliant explanation. Dr. Fuerch, if you mind to be here, just to some questions and answers. If you want to ask something to Janene, so this is your turn. So Martha and Julia are gonna help with that, with a microphone. There's some question for Janene. Yes? No?
Go back.
No? Everything is clear? So join this Spotify, LinkedIn, and inbox, newsletter.
That's good.
Yes, from Camelia, Doctor, please. Thank you. Microphone, this one.
Sorry. Yeah. Nice talk. Thank you, Janene.
Thank you for the invitation.
I was wondering what happens in 2020 for the approvals. You
I
know,
don't.
we should
Yeah.
repeat what happened there. I mean, of course, not COVID, but
Yeah, you can actually look at the details in things, and so I think there was probably a bunch that were, I mean, PMAs take a while, so I don't think it was exactly 2020 that made the difference, but it was probably all leading up to that, and there was probably a backlog in that time. People were working from home, so maybe they were less distracted and less traveling. I have no idea. But there was probably more applications, but some of those applications are like batteries. They're not necessarily incredibly influential things, but batteries for AEDs and other things. So you can look through the whole document and see.
some way were related to COVID or not?
No.
What do you, no.
No, there was not a pediatric waiver related to that.
Thanks.
They're doing a pretty good job processing things, and I know they get a bad rap, but they're actually doing a pretty great job. And we're more interested in hearing about CE mark and how to potentially get that, because that is what is making a lot of our companies nervous right now and coming to Europe.
Okay, thanks.
Thank you, doctor. And then next speaker, Dr. Blank.
Thank you very much, and I congratulate you for this nice organization. My question relates with small hospitals, how they do engage with your organization in a way to get more patients for rare diseases, for example, or so. Is that difficult? Are there fear, to enter in such a big organizations because then they believe maybe they are losing something? That's my question.
So you're talking about different companies that want to engage, or you're saying different hospitals?
Different
want to
hospitals,
engage?
hospitals.
So-
Companies I understand, but hospitals.
So it's interesting because we're part of Stanford Children's Hospital, but we actually are really outside of that. So we really based in, and so it gets a little, the lines get a little bit blurred, but we're really based at Stanford Biodesign, which is part of Stanford University and Stanford University Medical Center. And so we have an affiliation with Stanford Children's Hospital. That's where we do our immersion. That's where we do those things. And we are, several of us are clinicians there. However, I'm not up here representing Stanford Children's Hospital by any means. And so we are actually a very small organization. I say all that to say that we're actually not a big organization. We're a very small organization as Impact One. I mean, you're meeting most of the members today are here. And so engaging with us is not necessarily, I don't think people have too much trouble engaging with us. Whether it's talking about combining patients for rare diseases and things like that, I think that's something that the i4Kids team, is doing extremely well and much better than we would. So I would look to your own local resources for that one.
Perfect. There's still another question for Dr.
Thank
Fuerch.
you for your presentation. I am Luis Fernandez. I am Chief Scientific Officer of Adira Health, and we are actually based also in the Bay Area, and we are actually doing things here in Catalonia. You are doing an amazing job. I would like to understand a little bit how will you address dealing with pediatric innovation closer to primary care, community center, like Central Valley, rural areas, a little bit more underserved population, because sometimes they are disconnected from the children's hospital. Thank you.
Absolutely. So my husband's actually from the Central Valley, which is a very different place. If you know California, you always think about San Francisco, LA, and it's very rural. There's a lot of cows. There's a lot of, it's where you get all your almonds and walnuts and everything else from. So I think it's a great question, and we're starting to tackle that a bit. And I'm going to ask that you speak to Dr. Anu over there, because she is a primary care pediatrician, and we're actually trying to understand that network a little bit better and try to understand what their needs are and actually how to get technologies to them, because we agree that that's a huge problem. Their time is limited, especially when you're looking at primary care and pediatricians, but we're going to have more on that in the next few months. But you should definitely let us know. Come on over, and since you're local and everything, and we can chat more about how we can potentially help you too.
Okay, thank you. We have another one here, please.
Hello.
There were no questions, and now there are questions.
Yeah.
Okay.
No. Yes, and the last
needed
one
to
here
warm up.
maybe, no? This is the second line
Hello.
after this one.
We're
Congratulations.
here all day, so it's okay.
My name is Olman. I'm from the Health Catalan Quality Assessment Agency, and we work in innovation and foresight. And first of all, congratulations for the impressive presentation. So my question regards to, normally we see how, in terms of global markets, let's say an entrepreneur here or a startup or an innovation here has to think of how to get into the States, which is sort of an insurance-based model. How do you do the way around from an insurance-based business model? How do you think of serving or, let's say, defining the value for example, a universal model? Is it just a CE mark that you're worried about to get into this European market, or are you also concerned about how do you generate value for health public systems?
It's like we planted him. I don't know. I'm actually going to pause on that question because I don't know is the answer. And I don't know how you do that, and we think about that, and we think that a lot of pediatric technologies could actually be really helpful because their impact is quite long, and perhaps that's what public health systems care about a bit more. And that's why we're leaning on our i4Kids colleagues to actually help us with that. But your answer is going to be given in a couple minutes on how we're going to do that.
Great.
Okay?
Thank you.
Okay.
The coffee.
Spoiler
break.
alert. Spoiler alert. Yeah.
Hi, good morning.
Perfect.
Lucas
Yes.
Carwell, a pediatric surgeon from Barcelona. Congratulations
Nice to
on
meet
your
you.
talk. Nice to meet you. And your team, that I know some of them. So I wanted to ask you, you mentioned some grants for this pediatric consortium,
Yeah.
but I think they are restricted to US-based startups or companies. Is it going to be open or will be open
So I
to
told you the
European?
little secret. You might not have heard it. I slid it in there, as in you have to have a U.S. entity.
Okay, we'll talk about it then.
We support many different projects from around the world. I mean, in our portfolio, we have people from Sweden, we have them from Australia, we have them from all over. So there certainly are ways to do that so that you can get into all the consortia. We also allow some outside of that as well, as part of Impact One and the UCSF Stanford PDC. So, but we can talk later. But yeah, just Google U.S. entity, and it's pretty easy to establish. Yep.
Seems to be here in the Catalan Research Foundation. Come on. Thank you.
Thank you. Congratulations for your presentation. I would like to have any comment regarding when do you teach this kind of process, you know, this very well standard and improved process during the training of new physicians, new healthcare professionals, and so on, and what is its impact?
So we do it in a variety of ways, and I spent no time really talking about what we do at Biodesign. We have one 10-month fellowship that's highly competitive. We take 12 people from around the world every year, which, you know, more than welcome to apply for, but that's a full-time thing that's very challenging for people. We also have many different courses within the university that teach people at all different levels, from undergrad all the way to grad school. So we take it in a very large slice. The other thing that we do is we have a global faculty and training course that allows people to really immerse in this. So it really is immersion. You can't just do it on the side. You have to, it's really experiential. So you have to experience it. You can't just read about it. You can, but it's not, it doesn't feel the same, and you don't learn the same things. So this is not for every physician. This is not for every engineer, but I do think that it has incredible value. We also then do executive courses for, you know, Boston Scientific and all those people. They come in. The global faculty in training is really interesting, though, because we take, and I showed you the map where we have all the different programs around the world. We actually take people, immerse them at Stanford Biodesign and have them local for 6 months, and they're fully dedicated there, and then they go back and they teach their own teams, so it's kind of paying forward. If you're asking philosophically, when do I think we should teach people? I think the earlier the better. If you go into medicine with this type of mindset, you're much less likely to be, to believe when everyone says, well, that's just the way we do it. That's just the way we've always done it, which is a very common thing that we say in medicine. And maybe there's a different way. So I'm not sure if that answers your question, but we can always talk later too if there's more detail that you want there.
So please, he's still here. Another question, a little one, short, brief. No, it's okay. So thank you very much, Dr. Janene Fuerch. It's a powerful, tackled presentation.